Thanks everyone for inviting me tonight just to talk to you about the use of Gamma Knife for trigeminal neuralgia. So I've been in the community for almost 20 years, but we have this system called the Gamma Knife treatment for about 16 years. It's basically a type of machine that can deliver what we call stereotactic radiosurgery, which is a very precise way of delivering high energy X-ray at a image-defined target. In this case, for trigeminal neuralgia, the target will be the trigeminal nerve, obviously. Something about the Gamma Knife treatment, as I said, is basically, it's the name of the machine, but it can do what we call stereotactic treatment. It's typically delivered in one shot. Takes about an hour or so of treatment, or up to 5 treatments for other conditions. And some of the indications for Gamma Knife includes, mostly we use it for brain metastasis, for malignancies. But probably in our practice, it consists of about 60 to 70% of the case. But for some other cases, we also treat benign conditions such as meningioma, acoustic neuroma, schwannoma, pituitary tumors. And then for the functional disorders, we also treat trigeminal neuralgias and also movement disorders such as tremors, Parkinson-related, or essential tremors. And our functional disorder, like trigeminal neuralgia and movement disorder, only consists maybe about 10% of our cases. So at our center, we treat about up to 150 cases, 120 cases a year. So we kind of, majorities are for malignant condition, but about 10% for functional disorders like this. The new areas where we're thinking about are things like obsessive compulsive disorder. There's also a role for that, and also for epilepsy. It's not considered first-line treatment, but it's one of the options available. Just history on the Gamma Knife treatment, and it's been around for almost 50 years. The person who invented this was a neurosurgeon. His name is Lars Leksell. He's a neurosurgeon at Sweden. He's been doing this since back in the 60s. And the first cases he did was using a dental X-ray tube for basically trigeminal neuralgia. And since then, he developed this unit called the Gamma Knife treatment, where he uses 100 or close to 200 isotopes, cobalt-60, where it's all directed in one isocenter, one spot in space. And he can use this to treat basically any tumors in the brain. Since then, over the years, the system has been upgraded, updated. It's been, more things have been added to it, better planning, better software, better imaging, the use of MRIs. And this basically is the first system out there back in the 60s, where our first case was treated was a craniopharyngioma. This is really the first true Gamma Knife system. Our system is called the Icon. Basically, it's the newer iteration of the system. Has basically a bigger bore to accommodate a different type of patient, has more flexibility in treating different type of lesions, whether it's very peripheral, inferior. It can also treat head and neck cancer now. We can also treat all the way down to neck lesions too. Something about the Gamma Knife, basically, it's a system that uses, as I said, a cobalt-60 source, radioisotope. It has a 5-year half-life, so every 5 to 6 years we change the sources. It takes a lot of process in changing that. And it's a system basically where it had all those sources are pinpointed to one isocenter or one spot in space. So our system has 192 sources. The original system has 201 sources. They're all fixated to one spot in space. And when we treat the patients, we move the patient's head or the lesions to exactly where this all intersects in that isocenter. And that's how we deliver the radiation. Treatment, as I said, given typically in 1 fraction or potentially can be delivered into 5 fractions, depending on what we're treating or how close of a normal structure it is. So the advantage of using, some of the advancement in this system over the years has been better utilization of better imaging, MRI, CT scans. We also basically has better software for planning the system and a faster delivery of the radiation as well. So the first thing we do basically when the patient comes in for the treatment, we basically will put a frame on the patient's head. This is basically what we call the Leksell frame. This is accomplished by a neurosurgeon. So first thing we'll do is we'll put the frame on at the MRI suite. And once the frame is put on, then the patients will have an MRI that same day and with the frame on. So basically this will give us the reference point in terms of how to target the radiation. For trigeminal neuralgia, we need the MRI basically so that we can look for the nerve, depending which side, and then we can basically target it. So again, frame placement's done. Once the frame is done, we do the MRI, and then when we actually want to do the treatment, the frame is attached to the table, to the treatment table, and then the table move inside the machine where it actually would set up in the correct position for the treatment to commence. Just a picture of our machine. Basically, this is it's built essentially like a CT scanner. When the treatment is ready, the machine moves in, the doors open up. That's when the radiation is delivered. Each treatment typically takes about an hour or so. So if we do just one session, it's fairly fast. If we need to do 5 sessions, then maybe we do it within a course of like a week or 2. Our current system too is we can also, instead of using a frame, for some people who have a heart who does not want the frame put on them, we have an option of doing what we call a mass system, where we make a plastic mass of their head for the immobilization. Typically, we use that for a patient with brain metastasis with multiple Mets, so we can treat them non-invasively like that as well. And that will also allow us to do multiple treatments if that's what they desire. So some of the biggest changes from prior Gamma knife compared to the one we have right now is basically what we call the size of the bore. So initially, the original treatments were very tight, and the newer ones, basically on the right side, you can tell it's a lot bigger, so it allows more flexibility. We can treat more different patient type. It also allows us to go further down in the neck to treat some of the head and neck cancer, like nasopharyngeal cancer, and also some of the spinal mets as well. The team that's involved for the treatment, typically we have a neurosurgeon involved, we have a radiation doctor like me, we have a medical radiation physicist to do quality assurance, and also the nursing team. The main talk today, basically, we're going to just focus on the trigeminal neuralgia cases. Just give you a quick introduction on trigeminal neuralgia. Originally, my partner was going to give more of a talk on that condition, but so the condition basically is a diagnosis by default. So once you ruled every other thing, other dental pathology, it's typically described as a proximal sharp shooting pain that's involving either, it could be only one-sided or bilaterally. Could be even involving the forehead, the cheek, or the jaw area, depending which branch it's involved. It's a condition typically that's treated medically with medications, either with Tegretol initially, or maybe other medication like gabapentin, baclofen, or even I think they've used some of the antihypertensive medication as well. So if none of those medication works or patients become intolerant to it, that's when Gamma knife treatment is considered. It's typically, it's considered as a second-line treatment. I have some patients who basically tried medication right away, or they just don't like it. They can basically come to us and discuss this treatment right away. The main center, one of the main centers that's done a lot of these Gamma knife treatments is out at the University of Pittsburgh, where we get a lot of data. They were one of the first ones to do this type of treatment. Typically, the treatment, for this case, basically, most of the patients that are treated were what we call the typical type trigeminal neuralgia, but there's also the atypical type where patients presents more with dull, achy, ongoing pain. So it also can be used for that, but the success rate is not as good. In this case, in their series basically treated over 200 patients. The success rate basically has been pretty good. It's about most centers would report in an 80% rate. We also have presented our own cases. We also were basically following what everyone's getting, where we get an 80% success rate. It's a fairly successful treatment. 100%, most of these patients have been tried medication, and then about 61% also had tried surgery. The type of surgery they'll do for trigeminal neuralgia is called microvascular decompression. This series, the mean dose typically we give is about 80 gray, basically targeting the nerve as it basically exits the brainstem. We typically try to target about 7 millimeter away from the brainstem. Seems like that treating that has the best outcome compared to other sites of the nerve. The action of how wide radiation works for trigeminal neuralgia is not really well known. In some of the animal series, they think it causes some axonal degradation, maybe some necrosis on the nerve, or maybe some sclerosis on the microvasculature. But the main thing is it's not really clear why it works, but we do see the outcome. Basically, in terms of pain control, about 80+% of patients do get some relief. It's not something that happens right away. So the way we tell our patient, it has a delayed effect, a delayed onset. For our series, we basically see it about 1.5 months post-treatment. Most centers also see that about 1.5 to 2 months later, they get a response. It could range from a complete resolution of the pain where they don't have any need for any medication, or to a partial response where they still get some pain but requires ongoing medication for it. And for typical versus atypical, typical trigeminal neuralgia has a better response. That's where we get the 80% response rate. But for the atypical type, typically we only get maybe 50 to 60%. Patients who had prior surgery also don't do as well. They get more delayed onset for response, or some of them might not respond as well. And if for some cases, after 6 months, if the patients still don't have any response, then it's probably not going to work. The relapse rate is about 15%, 40 and 15%. That's what most series have shown. So after treatment, there's still a chance they can come back. Typically, we see it about 15 months after treatment. There's a chance it can recur. And so what we can do for those cases is, one thing, we can offer them a second treatment. We typically wait a year. If the pain comes back or the pain persists, a second treatment can be offered. So some of the side effects for this, one is basically is numbness, facial numbness. So potentially we can push it overboard where they develop facial anesthesia. It occurs, it ranges from 8 to 15% where it can develop this condition. Once it happens, it's a permanent condition. Most people actually, 80+% of patients, when we ask them, they actually prefer the numbness versus the pain. So it's a good side effects. Other things that can happen, sometimes the pain can get worse in less than 5% of the cases right afterwards, but it's usually temporary. And then less common condition like anesthesia dolorosa, trismus, changes in taste, corneal numbness, those are very rare, less than 2-3%, but can be seen in some cases. So just talking about other side effects, chances of damaging the brainstem is, again, very rare. The way with the accuracy of the treatment, we've never seen any cases where the brainstem gets damaged, so something that we have to consider, but it's a possibility. Bleeding is again, it's a possibility with those frame placement, but again, it's something's been reported but never been experienced. Other institutions like University of Kentucky, they've also looked at this, where they have treated over 250 patients. They kind of break down into, as I said earlier, what kind of response rate they're getting. So majority do get 100% response where the pain resolve with no need for medication, but some of them continue to need some medications where pain still persists, but still a lot better compared to before the treatment. In this case, they have a higher rate of numbness. I think it's because the dose that they used was a little bit higher. Retreatment is a possibility. As I said, if the first treatment doesn't work, we can retreat them. We typically wait about a year to let them heal and recover before we do the treatment. Several centers have shown that it's quite effective, ranges from 50 to 90% efficacy, but the numbness rate does go up. There are some cases where the numbness could be half the patients develop facial numbness. We do this routinely. A number of patients are retreat, or cases where we treat the other side if the one side works for the other. The surgical salvage, if after 2 treatments, if patients still having the pain, we can refer them to the neurosurgeon to do surgery, so it can be salvaged. Response is still good, but not in the 80%, probably more, 50% is doable. One of the problems when the patients do have surgery is there's more scarring inside the area. It's harder for them to do surgery. The type of surgery they do is called microvascular decompression, when they go in at the back of the ear, they do a small incision, and basically what they do, the surgeon does, the way it described to me, is they put a Teflon-like material around the nerve, basically to desensitize it. So it works typically better for patients with a known abnormal vasculature that's touching the nerve, but it can also work for patients with no abnormal vessels in the area. This is an MRI picture of the target MRI, the planning MRI that we use. So what we do is basically we do an MRI, identify the nerve. The neurosurgeon will help me identify that, basically, and then we will target it using our planning system. So we try to stay away from the brainstem, minimize the dose to that brainstem as much as we can. target the nerve about 7 millimeter away from the brainstem, and that's recommended from what our study shows has the best chance of success. Just more pictures on how the treatment's planned. Basically, once the MRI is done with the frame, it's downloaded to our planning system computer, so we can use that information for planning. We can shape the beam. This is for some other lesions, for if we need to treat a bigger lesion. The system allows us to basically do a volume or basically a more focal or shaping the beam if we need to. So safety-wise, the Gamma Knife compared to other systems out there, there's also other machine called CyberKnife or Linax that can also deliver high-dose radiation for treating trigem. This basically gives us one of the safest machine out there because it hardly produces any radiation outside the area that they're targeting. So people have done some studies where they measure the dose of radiation outside the isocenter where the radiation delivered. One of the graphs they produced basically showed that the Gamma Knife basically is one of the lowest ones where it produced the less radiation outside the body. So most of the data presented out there are done for treating trigeminal neuralgia, are done with Gamma Knife. People have also used it with CyberKnife. That's other machines out there that can do this, but it's not as well published. So overall, it's a treatment that's ideal for patients who already failed medication or a patient who does not want to be on medication. It's effective, safe, side effects is tolerable. It's something that can be redone again a second time if need be, or if it doesn't work, it does not preclude the patient from getting other treatments like surgery, or there's a condition also they can do what we call rhizotomy, where they can do numb up the nerve as it comes out of the brain, out the skull. So those are other procedures that could be considered if the treatment doesn't work, but it would not preclude you from getting that done. Any questions? Yeah. Go ahead.
With surgery, so specific to the treatment, how do you differentiate between when to do a surgery versus using Gamma?
Typically, when a patient comes to me, we refer, if they don't have a neurologist already, we typically get the neurologist, the neurosurgeon, and us. We discuss it as a group. So we do have a tumor board that we present all these cases, and then as a group we'll discuss about it. The surgeon will give their inputs, whether surgery will be an option or not. And then after we discuss it, then we'll offer them patients the Gamma Knife if that's what everyone decides. Typically, it's up to the surgeon first if they would see if surgery would be an option. As I said, typically they would offer surgery only if they see some abnormal vasculature that could be irritating the nerve. Those usually get the best response. So if they don't see any abnormal vasculature, then they usually will tell the patient to consider a Gamma Knife instead.
Approximately what percentage or ratio of cases is it caused by the vascular?
Actually, it's low. Probably I've seen it only probably 20% of our cases, majority, no abnormality in the brain or around basically where the trigeminal nerve is.
Outside of neuropathic pain, how do you use it for OCD? I'm curious.
There's certain, we haven't done it yet, but it's been presented in some centers, mostly from France, where they've done mostly functional disorders. But there are certain parts of our brain they will target. It's similar to epilepsy. For epilepsy, they will look for the area where the trigger point is, and that's where they target. It's not, and for OCD, it's been worked out. They target certain area inside the brain. I think it's the globus pallidus. I'm not 100%, but there are certain areas that they tried, and it seems to work. Yep.
So that they don't know the mechanism of action exactly on the trigeminal. What's the theory behind it?
The theory, I think it desensitizes that nerve. It causes some axonal degradation, and also, or if there's some micro vessels around the nerve, the radiation potentially would cause some sclerosis and basically decrease maybe those microvasculature, so it's not irritating the nerve as much. Or potentially just damaging the nerve, because the dose we give are excessively high. So it's probably damaging the nerve to a point that it's not firing as much. Yep.
Are there any trigeminal neuralgia cases that spontaneously resolve without treatment?
Typically not. Most cases that I've known for when I get the referral from neurologists or from dentists, they have it for years. I mean, there are years where it gets better, and then there are times that it flares up, gets really bad. Typically, these are patients that have tried multiple medications, and then, yes, there are times where it gets better or worse, and then once none of the medication works, then they come to me. Yeah.
To what extent does the numbness get experienced?
We typically see it in about 10 to 15% of the cases. Usually we see that in patients who have a response. So if the pain goes away, later on they'll tell us like a year and a half later that part of the face, they feel a little bit numb. Just like when you give an anesthesia to the local anesthesia to that area. After a while, they get used to it, so it's something that they don't consider bothersome, and they actually prefer that than having the pain. So, but if we do a second round of treatment, the rate of facial numbness sometimes go up to 50%. Go ahead.
What are your thoughts about ultrasonic treatment versus radiation treatment?
Yeah, one of the other options, I didn't really get to say it, but it's getting more popular these days, called HIFU, high intensity ultrasound frequency ablation. So rather than using radiation, it uses heat to treat that. We use that more for tremors, and seems like it has good response. Our neurologist, she's been recommending and doing more of that, but seems like after a couple of years, she started referring the patient back to us, but it doesn't seem like it works as well. But that's another option, using heat. So people have done it too for trigeminal neuralgia, not as much, but it's just another way of doing it. But the data is still, I think it's still preliminary. There are some success rate, but right now I don't think it's considered standard yet. Yep.
In dental surgery, we consider radiation to the jaw before doing surgery. Usually a threshold of about 50 rays-ish. If a patient reports head or neck radiation, can we just call you and say, hey, this patient reports radiation to whatever area? Did they receive more than 50 degrees of radiation to their left jaw?
Mm-hmm.
You can map that out and tell us yea or nay.
Yeah. This one with Gamma Knife, the dose to the jaw, unlike those head and neck radiation treatment that we do, is so minimal. Typically, it's not a concern at all. The jaw, the teeth, and the oral cavity hardly gets any treatment because it's so focused. But if they have head and neck radiation, those are what we call standard fractionated radiation therapy. They're larger fields. They cover a bigger area. Typically, patients get like 7 weeks worth of radiation treatment with concurrent chemo. Those basically, we can map out exactly, even with those treatment, with our technology now, we can map out exactly how much the jaw gets in terms of doses, and we basically can show you the CT scan of what the doses are. Yep.
On a related note, how tightly focused are the conversion beams, and what's your margin of error?
It's very tight. Basically, technically, inside those Gamma Knife machine, there's 4 millimeter shots, there's 9 millimeter, and then 12 millimeter shots. 4, 9, and basically, so we can, typically for Gamma Knife, for Trigem, we use those 4 millimeter shots, and the fall off the radiation around that 4 millimeter shot is very, very tight, less than a millimeter. So you're doing, so that's why we use the frame to really fix the patient's head in place, because you're dealing with millimeter changes, so it can make a difference if there's a movement. So with this treatment, that's why it's ideal for treating conditions like this. Those fall off from the treatment is so tight that hardly any radiation is affecting the normal brainstem or other nerves in that area. So we typically never see any other cranial nerve deficits after this, because all the other cranial nerves are protected. Yeah.
What factors do you use to determine whether you use Gamma Knife to treat like oral squamous cell carcinoma or those types of?
Right now, we don't recommend treating Gamma Knife for a head and neck cancer, because the problem with those is typically they're more extensive. We have to include the lymph nodes. Most patients have more advanced disease. And so for those, we do what we call intensity modulated radiation therapy. It's done with another type of treatment machine called a linear accelerator. Those are treated in bigger area, and they're typically given what we call fractionated over the course of 7 weeks. Those are we can make it very tight, but it's not as tight as this type of treatment. So that's why the Gamma Knife is ideal for brain tumors where you don't have to treat a bigger area because there's no drainage to the lymph nodes. You don't have to cover a big area. The limit of the Gamma Knife actually typically is about 3.5 centimeters. So tumors or target that more than 3.5 centimeters, this would not be ideal for it. People have pushed the boundaries out to 5 centimeters now for some bigger tumors, but typically the way it's done for bigger tumors, we fractionate it. Because biologically, it's better to fractionate it in bigger tumors in terms of sparing the normal tissue and also better tumor kill, just from our experience. Go ahead, sir.
Are you generally able to target a specific branch of the trigeminal nerve, or are you just after the?
No, we don't treat. Typically, people have done that in the past where they try to see, but now the recommendation is we treat as before it branches out. So we treat it just about 7 millimeter as it comes out of their brainstem.
So if they get the numbness, it's throughout the entire.
Potentially, but typically we notice the numbness. Typically, it only affects the area that initially where the patient was having pain. Somehow, I'm not sure why, but that's where they get a little bit more numbness. Maybe that part of the nerve is basically maybe abnormal, so they get more response to that area. But we noticed that area where they complain the numbness is typically the area where they were having the pain before. I don't think a lot of studies have been done why that's the case, but it's not the whole face being numb. Typically, it's more like it either affect the V1, V2, or V3 distribution of the cranial nerve, the fifth cranial nerve. Yeah. Any other questions? Well, thanks for allowing me to present this case. So any question, feel free to give us a call. Yeah.